Hello, I'm Dr. Rebecca Bowers, and in this video I will be discussing osteovision. When I was a medical student and heard some DOs mention osteovision, I would ask them what it was. Usually they'd smile cryptically and say something like, "You'll know when you know." I was not entirely satisfied with that answer, even if it is true. It's true that an experience can never fully be discussed in words, yet I also feel that there are some descriptions that can help people better understand a concept so they can be better prepared for the experiencing of it. So what is osteovision? For starters, it is a non-official term used by doctors of osteopathic medicine, DOs. It refers to the experience a well-practiced DO has when utilizing their senses to perceive structure and function in another person's body, even when direct palpation of the structures is not possible. The perceived experience may display in the conscious mind visually, spatially, a combination of the two, with or without other sensations. Here's an analogy for the difference between visual and spatial perception. Imagine you put a glass of water on your bedside table before going to sleep. You turn the light off and close your eyes. If you wanted to, you could probably see an image in your mind's eye of where the glass is on the bedside table. Later that night, after you've fallen asleep, if you woke up thirsty in the dark, you would reach for the glass using a kind of spatial sense of where it is. Some people might actually see the table and glass in their mind's eye when they reached for it in the dark, while others would just have a sense of where things are three-dimensionally and not much of a color image to go along with it. Regardless of what pops up on the display in your mind, it is possible because of our brain's ability to combine sensory information with other types of information like memories and present it to our conscious mind as a perceived experience. According to Stedman's Medical Dictionary, perception is the recognition and interpretation of sensory stimuli based chiefly on memory. It provides a cohesive, stable experience that permits interaction. It is different than sensation, although it relies on it. While sensation provides spatial information through modalities like sound, sight, touch, and temperature, it is perception's task to integrate and structure that information within a framework of past experience and knowledge. It is a representation of reality based on the observer's past and present experiences, including beliefs and biases, which is why two people observing the same thing may perceive it differently. And it's important to keep in mind that 100% accuracy can never be guaranteed. Answer this question the best you can without looking anything up. Which description best describes Reno, Nevada's two-dimensional relationship to San Diego, California, using the shortest route? In other words, Reno, Nevada is blank of San Diego, California. Is Reno northeast, southeast, northwest, or southwest? I'll give you a few seconds to think about it. And the answer is Reno is north and west of San Diego. Most people I've asked on the U.S. East Coast get this question wrong. Now, if you lived or visited these areas before or had studied the geography of the U.S. Southwest states, you are more likely to get the correct answer. But for people less spatially familiar with this part of the U.S., you are more likely to get the answer wrong. Your brain made a spatial guess, probably based on the following logic, either consciously or unconsciously. If California is a western coast state and Nevada is not, Nevada must be east of California. And since Reno is in Nevada and San Diego is in California, then Reno must therefore be east of California. So while 100% accuracy can never be guaranteed with perception, we can increase its accuracy through knowledge and experience. In order to perceive someone's internal anatomy as a 3D picture or 4D movie, we need a 3D knowledge of normal and variant human anatomy, which can be learned in books, videos, dissection labs, surgeries, etc. 4D experiences of the anatomy in motion that can be gained by paying attention to how one's own body moves, feeling how someone else's body moves, watching others perform various tasks and activities, and even reading about an activity and then imagining it in our mind. And also, we need lots and lots of practice palpating patients' bodies. Palpation is something all physicians are trained in, but to varying degrees. And while most DOs get more training in palpation than most MDs do, most DOs and MDs finish their formal training before their mind has had enough experience to create adequate spatial representation cognitive maps and perceive sensory input from palpation as 3D or 4D pictures in their mind. For someone who has never experienced this type of learned synesthesia, it may seem a foreign, far-fetched idea, but I hope to make it seem less so by discussing some of the science behind it, as well as sharing a few analogies and examples. The sense of palpation is made possible by mechanoreceptors close to the skin, which give mostly surface information, proprioceptors within muscles and tendons, which give information about location and position, both within ourselves as well as about objects around us and how we can move them and be moved by them. Proprioception is super important when palpating because it allows us to appreciate deeper structures, not only where they are, but what they feel like: soft, hard, stationary, mobile, pulsatile, and much more. We need symbolic memory of the 3D object we are interacting with, like words and pictures we studied in anatomy textbooks or heard in lectures, as well as spatial memory about the 3D object or similar objects we have interacted with in the past. For example, imagine being at the supermarket and feeling an avocado to determine its ripeness. When you first handle it, your mechanoreceptors will pick up on the texture of the skin, and when you give it a gentle squeeze, your proprioceptors will give you information about what's inside. If you have never seen the inside of an avocado, you will have a harder time picturing what you are feeling inside. But if you have, that symbolic memory will aid you. And if you have felt avocados to determine ripeness in the past, that spatial memory will aid your accuracy as well. Cognitive map is a type of mental representation about the relative locations and attributes of phenomena in our everyday or metaphorical spatial environment. Spatial representation refers to how the knowledge of space is represented in the brain, which we don't fully understand yet, but know it must happen since we are able to do things like ride a bicycle and shoot a basketball into a hoop. Imagine that you are standing in front of this open door and someone asks you to enter. Walk straight ahead to a chair, sit down in it, get up, and walk back out of the room. Even if you've never been in this room before, your mind will have a cognitive map of what the room might be like. Walls, ceiling, a floor, hopefully, and if you trust the person, a chair, plus maybe an uneasiness that there might be some other objects in the room. If you performed the task, you would likely do so slowly and cautiously. But if the person then flicked the light on and off, allowing you a glimpse of the room, you could proceed more confidently, and if you had performed the task one or more times, you would be able to navigate it without sight even more easily. Maybe right now you're saying to yourself, well, okay, I get how navigating the dark room would become easier, but I don't think I would actually see the room in my mind or as a map of it. I'd just move carefully and feel my way through the room until I got to the chair. That's because some of how you move through space occurs on a conscious level, but a lot of it occurs subconsciously. Yet the cognitive map is there and can be adapted to fit novel situations or new information. Example: have you ever been driving along in your car when suddenly you realize you got to where you were going without even really thinking about it? Your conscious mind was off wandering, preoccupied with other things, while subconscious mind took the conscious desire to drive to a location and on autopilot made it a reality by combining the pre-made mental map with the present sensory info and having you perform tasks without you even being fully consciously aware of it. But it is also possible for the reverse to happen, for the conscious mind to access these subconscious cognitive maps and make conscious use of them. I'd like you to close your eyes and picture the outside of the home you grew up in. Can you see it? Can you imagine opening the front door and walking around inside, moving from room to room, navigating around furniture and past windows and doorways? Even before I asked you to picture your home, your subconscious mind already had a visual and spatial map of your home. But once you instructed mind to access it, it came up onto the screen or holodeck of your conscious mind. Maybe not super in focus or detailed, but something visual and or spatial came to mind. Now imagine if you were returned to the front door of this childhood home blindfolded and told to navigate to your old bedroom. You are most likely going to pull up a cognitive map of the inside of your house, and it will aid you to get where you need to go, even if someone had remodeled, even if they changed the furniture or rearranged some walls. It's easier to bring this map to consciousness because you are so very spatially familiar with it. The more you use and consciously access a cognitive map, the easier it becomes for your mind to blend and integrate the conscious and subconscious information in real time to form a four-dimensional interactive movie in your mind. So with anatomy, that means it's not just enough to study the 2D pictures in textbooks. You need to move your conscious awareness from one structure to the next in 3 dimensions, which is what dissection labs, surgery, radiology rotations, and palpation can help with. Also, at other times, you can practice by closing your eyes and imagining going through the body from one structure to the next, sometimes pausing to look something up and fill in the gaps as you encounter them, or just doing the best you can with what you remember. This can be done 2 ways. 1, you can close your eyes and picture in your mind's eye a body or focus into a particular area or organ system and trace the pathways, see the pathways in that body based on your knowledge of anatomy. Or 2, you can relax, close your eyes, and proprioceptively ground yourself, getting a feel for where you are in space and where different parts of your body are. Then focus into a particular area or organ system and trace the pathway, see that pathway in your body based on your knowledge of anatomy. At first, it will not be very detailed or precise, but the more you study and spatially interact with anatomy, the more your cognitive map will update. Since anatomy is alive and moving, it's also important to familiarize yourself with how it moves. You start with concepts like fulcrums, levers, loads, effort, and vectors, but since the body has a large number of muscles and other soft tissue attachments with variable orientation, this results in shifting fulcrums both within the joints and outside the joints, and the number of fulcrums and locations of fulcrums will depend on the job the body is trying to do. So it gets conceptually complicated pretty fast. And biomechanically, thinking about things in a linear fashion, like if my ankle is turned this way, then my knee should be that way, and my hip would be doing this, etc., while useful thought experiments to practice, will never fully capture the complexity of movement in a multidimensional living human body. Especially once you factor in the 4th dimension of time, aka movement. Complex computer programs are usually required to plot vectors in 4 dimensions. Luckily for us, the human brain is a complex supercomputer with the majority of processing occurring behind the scenes in the subconscious, and what pops up in our conscious mind is like what appears on a computer screen. With the right programming and commands, more of what is usually running in the background of your mind can be brought up onto the screen of the conscious mind. But it takes lots of practice, both repetitious as well as approaching things in novel ways so that your subconscious mind can better relay the information to your conscious mind. So what is osteovision? It is a term that refers to an ability of well-practiced DOs to pick up on subtle visual and palpatory cues and based on their experience and knowledge of human anatomy, physiology, biomechanics, and behavior, to see somatic dysfunction and perceive how it is behaving. It is experienced in different ways by different DOs. For example, I know a DO who told me that they see red in an area of the body that has somatic dysfunction, and then they will go to that area and work on it, and the area will look green once the somatic dysfunction has been adequately treated. Now, does this mean that there is really red or green light in the patient's body? No, but that is how this DO's subconscious mind was able to feed the location of somatic dysfunction to this particular DO. For me, I have experienced osteovision in different ways at different times. Sometimes it's like I have on augmented reality glasses and can see, feel what the dysfunction is as I watch the patient moving or examine them with my hands. Yet other times it presents itself in different ways. For example, one time I had a patient come to see me who complained of pain in multiple areas of his body, and in the history he mentioned how a couple of years before one of his children had gotten pulled into a riptide and he had had to rescue her, and it had been a very difficult experience on his body. Since when an experience is not fully processed and integrated into the nervous system, the body will often still be holding itself and/or micro-moving like it had been during the traumatic event. So I started my exam thinking I was going to feel a man being pulled by the ocean and/or desperately pulling on his child. Yet instead, his body didn't fit that pattern, and when I got to examining the front of his neck, I was filled with an overwhelming sense of terror and dread, and in my mind's eye, I saw a rope. So I asked, "Have you ever had any trauma to your neck?" He looks like he's thinking about it. So I go, "Especially to the front of your neck, like with a rope." "Oh," he says, "years ago I was skiing and someone had roped off a trail, but I didn't see the rope and I skied right into it. It hit me in the neck so hard it yanked my ski helmet strap right off and over my head." This is what we need to work on, I told him. It's what is playing out most strongly in your nervous system. So what might osteovision look like to you? How will it evolve and change as the neuroplasticity of your brain adapts and changes to the attention and importance you are putting on different sensory information coming in and the problems you are asking it to solve? Only one way to find out. Study, practice, proprioceptively ground yourself, let your conscious mind take the back seat, and allow yourself to become immersed in the now. There's often plenty of time to think about what you felt later, but first you need to get out of the way and experience it. Once your conscious mind starts accessing more and more subtle sensory data, it will be easier for your subconscious to feed you more and combine it in novel ways. I made this video as a resource for other physicians and body workers. Please do not attempt to perform any manual techniques unless you are a physician or body worker or a student under proper supervision.